Welcome, everyone, to our So Your State Just Enacted and RDAC Now What webinar. I'm Rachel Schur, Vice President of Policy and Regulatory Affairs here at NORD. We're really thrilled to have so many familiar and new faces join us from the rare disease community to formally launch yet another RDAC toolkit. This third toolkit is focused on the implementation phase of an RDAC. I'm going to turn it over to the policy team in just a moment for more information and a walk through the toolkit. And then we're going to have a really great panel discussion with RDAC experts. But before I do that, I just want to take a moment to thank the sponsors for their commitment to the success of Project RDAC. I want to thank Alexion, Biogen, Bluebird Bio, Boehringer Ingelheim, CSL Behring, Genentech, Verizon, Pfizer, Sarepta, Takeda, and Vertex. Without our sponsors, Project RDAC just would not be possible. As of today, there are 17 states with RDAC legislation that has been signed into law, and 3 other states, including New Jersey, Florida, and Louisiana, with bills on their way to the governor's desk. Additionally, a few other states, including Maine and California, are making some really great progress. The team's going to share an update on all of the legislative activities in just a bit. We're so excited again about leading Project RDAC and the promise that it holds for getting more RDACs in place. So I will stop talking now and turn it over to the policy team for more on Project RDAC, background on the toolkit, and get started with our really wonderful panel. Thanks so much.
Great, thank you so much, Rachel. So I want to do an overview of some of the work that NORD has been doing to support state RDAC efforts. So we want to continue increasing the number of RDACs throughout the country and continue to work to strengthen existing RDACs to give as many rare disease advocates a voice in state government as possible. NORD has worked to develop state-based RDAC coalitions to support and provide opportunities that encourage RDAC collaboration. NORD highly encourages that different state RDACs collaborate with one another to share ideas and best practices. We plan to continue to develop and release toolkits and one-pagers, host webinars, and convene additional meetings to support ongoing RDAC work. Great, next slide, please. So this is just a quick snapshot of our policy team and how our Eastern and Western regions are divided. So let's start with the problem. So more than 25 million Americans are living with one of the more than 7,000 unique rare diseases. So this breaks down to about 1 in 10 Americans. So even though that might seem like a lot of state decision makers still have limited awareness of the issues and impact that rare diseases have on patients, their caregivers, and the overall healthcare system. Okay, next slide, please. So what is the solution? NORD believes it is to create a diverse body to advise state government on the common obstacles that the rare disease community faces. We see this as an enormous opportunity for government officials and the rare disease community to work together to develop resources necessary to prevent and address barriers in a strategic way. So there's a number of differences between each RDAC, which includes the number of members on their council, varied members of the rare disease community represented on the council, differences in where the council works out of, the number of members on the council, funding and duties and accountability mechanisms. So overall, each RDAC has the same goal of supporting the rare disease community by increasing the voice of rare disease patients and caregivers at the state level. Next slide, please. Great. So as mentioned, to date, 17 states have passed RDAC legislation. We also have several other RDAC bills that are currently being heard in other states. So now we're going to give a few updates on our states here. So I'll start with some Eastern region updates, and then I will turn it over to Elise, who will dive into the Western region updates. So the RDAC legislation in Florida has made its way through the legislature, as mentioned. Florida's governor approved the state budget last week and is now beginning to review legislation. So we are expecting the Florida RDAC bill to be signed into law within the next 3 weeks. New Jersey's RDAC legislation has also passed through the full legislature. New Jersey's legislative session is going to be wrapping up soon, so we do anticipate that the governor will review the legislation within the next 3 weeks as well. Next, Maine's RDAC bill unanimously passed through the House and Senate. So at this point, the bill needs to be reviewed one more time by each chamber, and then it will also be on the governor's desk. Michigan's RDAC bill was heard in the House Health Policy Committee last month, and then was reviewed within the committee in a work group session. So currently, the Michigan bill is being further reviewed for some potential amendments, and the committee will then vote on it within the next 2 weeks. South Carolina's RDAC bill passed through the full House before adjourning and will be heard again in a Senate committee this coming January. And lastly, Mississippi introduced RDAC legislation early in their session, which unfortunately died quickly, but we are looking forward to working with our Mississippi advocates in 2022 to get it reintroduced in the state. So with that, I will now pass it over to Elise Patel to provide some updates on the Western region.
Perfect. Thanks for sharing some of the RDAC progress in the eastern part of the country, Anissa. And hello, everyone. My name is Elise Patel, and I serve as the NORD State Policy Manager for the Western region. And here in the Western region, we had 3 states that introduced RDAC legislation this year. Arkansas was the first to do so. And while we were unsuccessful with getting the RDAC established this year, we'll definitely be working on it again in 2022. California's RDAC bill passed through the Senate unanimously at the end of May and will soon make its way through the California Assembly. And as mentioned earlier in the presentation, we're anxiously awaiting the governor of Louisiana to sign their RDAC legislation into law any day now. So we're continuing to build out our RDAC coalitions in Washington and Texas and Wisconsin, and are anticipating legislation to be introduced in Wisconsin later this summer. And thanks to all of you, we've really made some wonderful progress throughout the country this year in regards to RDACs. And as we work on identifying our target states for 2020, we welcome you to email us at rdac@rarediseases.org if you're interested in helping with any efforts in your state. So today, we're really pleased to be walking through some of the highlights that you'll find in our 3rd RDAC Toolkit that's designed to help with implementing an RDAC in your state. And you'll have the pleasure of hearing from rare disease advocates and RDAC leaders who are part of existing councils during our panel discussion a little bit later. So as Anissa mentioned, and we can go to the next slide, please. Project RDAC was launched as a way to provide assistance to RDACs at every step of their journey. And back in January, we shared our first toolkit that provides a step-by-step guide to building a diverse RDAC coalition and also helping determine the purpose of your council. Our second toolkit was released back in March and serves as a comprehensive guide to the legislative phase of an RDAC. It includes legislative resources on the legislative process, suggestions for how you can engage with lawmakers, advocacy recommendations for the RDAC coalition to be involved with. And then our third toolkit and the focus of today's webinar will be an overview on how to implement an RDAC in your state, from member appointments to structuring your first meeting, creating recommendations as a council, and then how do you report those back to state decision makers. So your RDAC coalition has been most likely an instrumental part of your state's success. And I'm excited to share some tips on how your coalition members can continue to assist in the process of getting your RDAC operational. And the very first tip is take time to celebrate your hard work. You've not only accomplished building a strong coalition, but you've navigated the legislative process and have managed to get your RDAC across the finish line. And we at NORD really want to help ensure your RDAC is implemented successfully. And in order to do that, it's important to review your state's RDAC law to check on critical pieces that will both establish key dates and the timelines with regards to the RDAC. So within the statute, you'll find who will be tasked with appointing an RDAC chair, which usually will take place within 30 days of enactment. And then that will be followed by additional information such as when the very first meeting should be convened. And typically we found that these first meetings take place within about 90 days, but again, this is going to vary state by state. And like the legislative phase, it's essential to identify a coalition member that can help stay in regular communication with both the RDAC bill sponsor as well as those that are responsible for helping to appoint people to the council. And keeping this line of communication open will not only show the coalition's support of the overall process, but help prevent any challenges that might occur when it comes to meeting deadlines during the implementation phase. And during this time, it's also important to continue your outreach to the rare disease community and share information about what the council will be working on, their duties, as well as different opportunities for how they can stay engaged. And I know we've said this a lot, but each state truly is unique when it comes to RDACs. And that holds true for the membership of the council and the application process. Because it's recommended that RDACs have between 12 and 15 appointed members, it's not possible for everyone to serve in a formal capacity on a council. But even without serving a formal capacity, coalition members are still a critical piece, as well as others of the rare disease community, and an important voice to bring to the table. And later today in our webinar, you're going to learn about ways to develop a robust strategy for public engagement. And please know that by serving on a coalition, that does not guarantee RDAC membership on a council. So as you're starting to build out your RDAC, if you're experiencing any difficulties when it comes to gathering applications for the roles on the council, NORD is happy to engage our Rare Action Network to publicize the opportunity and also how the process is handled in your particular state. And this is also a wonderful opportunity to engage, to have coalition members engage others in their networks within the rare disease community. So very important, make sure you pack your patience when it comes to the implementation stage of an RDAC. Typically, we found that it takes between 3 and 6 months from the time a bill has been passed and signed into law until the RDAC has actually completed its appointment process. So with that, I'm going to turn it back over to Anissa, and she can help provide an overview of the 4 main phases of creating a high-impact functional RDAC.
Great. Thank you so much, Elise. So although being appointed as the chair or vice chair of an RDAC is very exciting, it can sometimes be challenging to determine where to start and how to determine the next steps. So I'm going to share an overview of some tips that can be helpful. So as a leader of an RDAC, we recommend beginning to focus on ensuring that a smooth implementation occurs. Although there is not a uniform way to do so, we have found that following these steps can be a useful guide. It's important to note that this is just an overview, and we will discuss this more in depth in our panel discussion. We really appreciate all the feedback that we got from existing RDACs. These phases were created based on input from current RDAC leaders. So phase 1 consists of the initial setup. We recommend reviewing information within the bill about what the appointment process looks like, anticipated deadlines for appointments to be made, and the date that your first meeting is expected to occur. It's helpful to have a strong government contact, especially if the RDAC is going to be housed under a state agency. This is going to help give you an understanding of how your state's appointment process will be handled. After all positions have been filled, it's time to begin preparing for the first RDAC meeting. It's beneficial to ask the members to introduce themselves, to share their backgrounds, discuss common challenges that the state's rare disease community faces, and to discuss logistics, such as the frequency of meetings and if the meetings will be virtual or in person. It's really helpful to also send a brief follow-up email to the members with any action items that the council has agreed upon. In the second phase, focusing on what the council wants to begin prioritizing is a great next step to take so the work can begin. The second meeting will often focus on identifying the council's priorities, their vision, and how goals can be accomplished. It's also great for the council members to familiarize themselves with the duties that are outlined in the bill language so that they're aware of what the council's expectations are. Another valuable item to discuss is how the council is planning on engaging the public and providing a consistent forum for individuals within their state to share their insight and discuss their concerns. The third phase is focused on ongoing operations, government engagement, and ensuring compliance. So this is a great time to review appropriations, if there are any tied to the council, to determine if there's any reporting requirements and how to best utilize funding. It is also recommended that the council work to identify a strategy that will allow them to stay up to date on the state's legislative activities that are relevant to the rare disease community, so that they are able to consistently come together and weigh in on these issues. The last phase that we recommend is to focus on maintaining long-term success of the council and thinking ahead. It's helpful to continue to monitor appointments and to come up with a plan when a vacancy occurs within the council. Some bill language includes protocol for how to handle vacancies, and it's recommended that you check in with the housing entity when one does occur so that the seat can be filled in a timely manner. Continuing to strategize with the council on what they want next steps to look like and goals that they have for the future is a helpful conversation to have to maintain productivity and a strong vision. Using the council's website is a great tool to provide meeting minutes and helpful resources for your state's rare disease community to tap into. Finally, we recommend returning to the legislature as needed to seek public funding or to adjust the law to help address identified challenges or barriers to success. Next slide, please. Perfect. So the toolkit has several helpful resources for RDAC leaders to utilize during each operationalizing phase. For instance, the resource that shares criteria for strong applications is helpful for the first phase. A sample agenda is available to help prepare for the first meeting in the second phase. It includes a sample presentation that can be used when presenting to legislatures in the third phase, and it includes criteria for how the council can maintain a strong website to help continue sharing their vision and next steps with the public during the fourth phase. So again, this is just a snapshot of some resources that the toolkit has. We really encourage you to check it out and download it from our website for more resources that support RDAC leaders. So with that, I'm going to go ahead and turn it over to Rose Gallagher to introduce our panelists.
Thanks so much, Elise. Thanks so much, Anissa. Good afternoon, everybody. My name is Rose Gallagher, and I'm NORD's Associate Director of Policy. I'm really excited to kick off our panel discussion today. We have Representative Tony Albright of Minnesota's 55th B District. Who's a member of the Minnesota Chloe Barnes Advisory Council. We also have Dr. Amber Federizo, who's the Director of Research in Hemostasis and Thrombosis at the Thrombosis Center of Nevada, who's also the chair of the Nevada RDAC. And finally, we have Dr. Terry Jo Burchell, who is the Vice Chair of the Tennessee RDAC and founder and director of Combined Brain, and a Tennessee RAN ambassador. I'd like to start off with kicking it over to Representative Albright to introduce yourself and share a little bit about what position you hold on your state's council and why you decided to ultimately get involved in the RDAC in your state.
Thank you, Rose, for this opportunity, and I welcome the opportunity to share some of the work that we've done and the insights that we've had in moving forward. The RDAC that Minnesota has enacted into law was first started in 2018, and it really comes out of kind of a statewide initiative, particularly with our University of Minnesota, the Mayo Clinic, and other research facilities that we have in the state of Minnesota that really found it a compelling argument that why aren't we doing more for those that are suffering from such dread diseases that even though they may be few in number, the need for care is just as important and urgent. And so we took that upon ourselves to put a committee and a program together that not only served the patients and those families with individuals with suffering from diseases, but also as a platform for dissemination of information to the others around the state to help facilitate those states that don't have an RDAC as well.
That's great. Thank you. And thanks for being here today. I'd like to turn it over to Dr. Federizo. Can you introduce yourself and share what role you have on your council and why you decided to get involved in your state?
Sure. Thank you for the opportunity to come and talk today. My name is Dr. Amber Federizo. I'm a family nurse practitioner, and I treat rare inherited bleeding disorders across the entirety of our state. So it's always been immensely important to us at the Hemostasis and Thrombosis Center in Nevada because we cover the entirety of the state, all 110,000 square miles. So when we talk about rural rare disease, we know about rural rare disease and some of the people that get left behind. So we are very passionate in making sure that the access to care across the state is equitable and really trying to reach and advance it statewide. And that's how I became involved and then selected as the chair for our Rare Disease Advisory Council here in Nevada.
That's great. Nevada's definitely in good hands. And Terry Jo, let's turn it over to you. Can you introduce yourself briefly and share what your position is on the Tennessee Council and why you decided to ultimately get involved?
Yes, I'm Dr. Terry Jo Burchell, and I am really excited to be the vice chair of the brand new Tennessee Rare Disease Advisory Council. I decided to get involved because I'm the mother of an adult son with a rare disorder, and I am the wife of a physician who treats children with rare disorders and the daughter of a father with a rare disorder. And what I've seen is that many times treatment, diagnosis, therapies all fall through the cracks. And our state of Tennessee has a really big problem with healthcare coverage and with healthcare services, especially in the rural areas. And I felt like this would be a fantastic way for us to provide a voice to all those families.
That's great. Thank you so much for being here today and sharing your expertise and wisdom. I'd like to bring it back over to Dr. Federizo for a second to share a little bit about what year the Nevada Council got off the ground.
So our RDAC was enacted in 2019. We were originally scheduled in early of 2020, and the pandemic really kind of took everything and turned it upside down. And so we actually did not start meeting until November of 2020. So in terms of infancy, we're really only 6 months old. We're very, very new still. So we kind of got a light start, but we're now headed in the right direction.
That's great. And Dr. Burchell, what year did the Tennessee Council get off the ground?
Well, the law passed about 1 minute after COVID hit the state, and it was signed by the governor last summer, and we actually started working all on Zoom last September and October. And we've been meeting monthly since November. So we are also really a newborn RDAC too.
Yeah, it's exciting. We have some newer and older perspectives today to talk about, RDACs and how they are getting off the ground. In NORD's toolkit that we just released today, we share a roadmap for the coalition that helps the RDAC ultimately get through the legislative process. And then also for the RDAC members that are appointed to lead the RDAC, like our three panelists today. So I'd like to, for the purposes of today's panel, as we move on and talk about some of the early steps that Tennessee, Minnesota, and Nevada are taking, I'd like to share, to go back to Representative Albright for a second, if you could talk a little bit about some of the early steps that the council decided to take to get started.
Yeah, we're fortunate that we were enacted into state law back in 2018, so we did have a fair amount of time provided to us before COVID really shut us down on March 17th when we went into lockdown. But I can tell you that it wasn't difficult to find people that wanted to serve on our RDAC. Quite the contrary. I think we had an overabundance of people that really had a passion for this. That particularly comes out of the bounty that we have for the medical community in Minnesota. But I will say that it is important, and from our perspective, that you have a committee, and we found very often that we have a larger committee, and then we have sub-working groups, particularly along specialization or their passion, if you will, whether it be endocrinology, the myelitis. You can, certainly consider the number of subsets that really had a passion for that. And so we quickly understood that in order to tackle these very specific issues, we needed to break it down into subsets. And then we also established a subcommittee executive board that was kind of a gatherer, but also a coordinator for the information that was derived from those subgroups. I would point out that we do have a very strong executive director for the overall RDAC, and she has just done a fabulous job of not only coordinating the information, but providing a platform for voices to be heard, whether they be from the committee as a whole, or in particular, hearing from outside sources that would wish to provide us with data. And I think that's really, really an important function in terms of being a collection point for all of these families, as well as the caregivers and researchers. And then how do you distill it down into meaningful information?
That's great. I think that's really good advice. When you get started, some of the subgroups that the Minnesota Council created, I think have been, like you said, really instrumental in getting the council off the ground and accomplishing the work that you all have to date. As we talked about a few minutes ago, Nevada and Tennessee are on, the newer side. Dr. Federizio and Dr. Burchell, can you share a little bit about what your first meetings look like and some of the early steps that your council has taken to get off the ground in your states?
Sure. Would you like to go first, Dr. Federico?
Oh, no, go ahead.
Okay. So there were a couple things that we did right away, and we're still really hammering out exactly what we want our role to be. But one of the first things we did was craft a survey for all rare disease patients in the state of Tennessee, and we borrowed heavily from RDACs from other states that had gone before us. So we basically converted surveys that had already been used by other RDACs to fit in Tennessee, and we've just launched that. And part of the other reason, the other thing we had to work on was creating a website so that the public can find us, so they can find the survey, and so they can tell us what they think about their lives and issues in Tennessee. And then the other thing we did that I'm proud of is we set each member of our RDAC to be a liaison to one of the other councils in the state. So the Council on Disabilities, the drug utilization review boards, all the different other state councils that have some relevant subject matter, the newborn screening group, we have a liaison, and that's actually really helping a lot.
That's great. That's really interesting. I think that's a good piece of advice for newer councils who are joining us today, making those early connections and getting out there in your state to, so that folks know where to go when they have questions about rare diseases is just a really, really good first step. So thanks for sharing that. And what about in Nevada? What are some of the early steps?
The first meeting that we had was over 3 hours long. We did not have much direction. I think that everyone kind of wanted to do something and come together, but we didn't know, what does an RDAC do? What are we legislatively allowed to do? Many of us were new to open meeting law and some of the structures that we needed to learn. And then additionally, we were under DHHS, so we were afforded a website, but it was kind of tucked away within the state's website. And so we talked about, how do we create our own, with the exception that we have no funding at all. So we don't have, unfortunately, some of the more assets like having the administrative assistance with an executive director. And was really spent a lot of time forming who we are and what it is that we as a council could realistically look at. We knew that our council's small, and so we would have to narrow the focus within rare disease until we gain more experience. So we actually narrowed it down to 3 different categories that we would focus on in terms of rare disease, and then eventually expand it out and take a look at using our website as a registry of diagnosis. So instead of patients trying to go online through their insurance and trying to find the hematologist, they were actually looking for the disorder they were diagnosed with. So they could go in and say, I have hemophilia, and they can get a list of providers and go about it that way. So a lot of the early days was trying to figure out how to do this. I wish in retrospect there had been more discussion to our state from other states' RDACs, because our state didn't seem to know either in terms of our scope. And we had legislative objectives, but really no guidance or direction into how do you start and where do you start.
Yeah, as a follow-up question, can you talk about the 3 buckets that you just identified, some of the early pieces of work that that you all decided to focus on? Because I think, you're definitely not alone in that some of the first RDAC meetings can be lengthy, right? I mean, it's a big goal to take on in your state, to increase the representation of rare diseases and be a voice in your state government. And so can you just talk a little bit more about that?
So we narrowed it down to the council's expertise. So we presented inherited bleeding disorders and inherited clotting disorders. And then we also focused on our newborn screening program as a state. We used to have that kind of tailed off to Oregon. So Oregon used to do our newborn screening, and now it is within our state. So it was something we knew needed focus on. And then we had a very strong side for rare childhood cancer and those elements that are still needing to have focus. And so we really wanted to make sure that we were engaging our council members, because we realized this, these aren't paid positions. You want to advance, you have that passion, but to just kind of pick a rare disease where no one really knows anything, or perhaps really wouldn't have allowed us to focus in what little resources we had. So we selected those ones. And then as it goes, we have anticipated plans of adding more in as time goes on.
That's really interesting. Yeah, thanks for sharing that. Representative Albright, can you talk about some of the, you alluded to some of the early work and how you got, set up in Minnesota, but what are you all, currently working on in the state?
I think I'm going to maybe segue off of a couple of comments that I've heard from the other panelists. And I think one of the things that our RDAC has really, we were going along well, and we had differentiated ourselves in terms of, rather than 3-hour meetings at the executive board, we really said to the subcommittees and the working groups that that's where the amount of time necessary is unlimited, right? And then that distillation comes down, and then they report back to us on a regular basis through the executive director. But I think it's important to remember, and I heard this brought up, that in most cases, enacting language does not come with a roadmap. What it does is it allows you the opportunity to struggle with what you want to be when you grow up, and I think in a larger sense that's good. But I also think, as I've heard, RDACs, it is a passion, and the people that are involved in these initiatives have a very, very strong emotional attachment to this, and that's why they're involved. But the problem is that then it's almost like herding cats. You want to help everyone, and you want to do everything for everyone. And what we identified just recently, and I actually requested a forum with the executive board, is to decide what is our strategy from a perspective of state your intentions almost, because we are constricted, or we are obligated to follow the law. And that law is ambiguous to the extent that we are not in the pursuit of practicing medicine per se, nor are we really relegated to make inferences and favoritism of certain methodologies or institutions over others. While our fiscal agent for this RDAC is the University of Minnesota, they are also obligated to keep us out of trouble legally. And so, as in many other states, the RDACs really come to a point where I hear from our folks in Nevada where you have to really decide what it is that you want to focus on. And what we have kind of come to a realization is that we are a disseminator and a collection for information that can help the families and those afflicted by rare diseases. We're not a UL or a Good Housekeeping seal of approval. That is for the patients and that is for the doctors to work out. But we are a promoter and an advocate for better healthcare for those that need it so desperately. And I think the survey really bore that out in terms of the dissatisfaction that we discovered. It's almost like you don't know what you don't know until you really do dive into the details about a survey. And we were frankly surprised at how difficult it is to disseminate that information, particularly when you're not dealing with large groups. And general practitioners are not aware of the issues, and specialists are few and far between in terms of distance and availability. So we're blessed to have a number of institutions in the state that can focus on with their clearinghouse of information over many, many years. But other states are not as blessed with those. And so we feel it almost as an obligation to share that information with the rest of the country. And so we have taken that mantle upon ourselves to be the advocate for the nation in terms of rare diseases through the work that we do on our council.
Yeah, that's great. Thank you for sharing. I feel like we could end the panel right there. That was a lot of really helpful insight, and appreciate you sharing that background on the survey. Terry Jo, could you talk a little bit about your survey? I know that you spoke about using other states as a guide, but if you're a new state coming online as an RDAC, how can they go about setting up a survey? What tips would you share for them as they get started?
Well, the very first thing is to, and this is a pitch for the toolkit, but really just access everything you can through NORD that NORD has already done, because there's no point in starting from scratch or remaking the wheel. And so what we did was just take those surveys that were already done and just barely change them at all. And I think what we're going to see is after we get our first results, which we're just now getting responses, then we may very well need to change it and make it more state specific. But right now it's a good survey borrowed almost lock, stock, and barrel. I want to say one other thing that we do that I'm proud that we've done. And also one other problem that we've had. So one thing I'm proud that we've done is we start every meeting with a patient telling their story. And by doing that, it keeps our heads on straight about why we have the RDAC. And it also gives us actual personal knowledge of people across the state. It's a long, skinny state. It's pretty far from one side to the other. So it helps us meet people from all over the state and understand what their lives are like. So that's one thing. And then one problem we've had, and I would love feedback, but maybe that would have to come at a later date, is how do we weigh in on legislation? And that's something that we really haven't figured out. And so at this point, we think what we're going to do is provide a report every year based partially on the NORD report card, partially on our survey responses, and partially on feedback that we get from the council members, and have that report every year just talk about the state of the state and what we think, what recommendations we would like to make. And that way we're not weighing in on specific legislation. But that's just what we think at this point.
I think that's really helpful. Representative Albright, if we could turn it back over to you for a second. I mean, what are your thoughts there as a, current state legislator? What are the best ways for councils to engage with their, elected state officials?
I think RDACs are in a very desirable position to affect legislation, but the manner in which you do that, I think, is a very tenuous proposition, because you can be an advocate, but you can't be a lobbyist. And so I think the tack that Tennessee has taken is the one that we've also taken. But in terms of a report card, the state of rare disease, if you will, back to the legislature on an annual basis to not only market the efforts of the RDAC, but also maybe give fair warning in terms of what they're finding out over the past 12 months. I think it's imperative that legislators are included and have a very hands-on approach and facility to your RDAC. We appointed 2 from the Senate and 2 from the House, 1 from the Democratic caucus and 1 from the Republican caucus in each House. So it is strictly bipartisan. And that in and of itself really speaks to the bipartisan kind of all-in approach that we have taken with our RDAC. And I think we have strong buy-in from, obviously, from our charter institution, the University of Minnesota. We're very blessed with some people that are just incredibly gifted, not only in medicine, but attacking problems from an advocacy program. So it's imperative that you get your legislature involved in your RDAC as a liaison, because they can speak directly to that legislation without having to worry about that annual report coming and then reading it, because they're going to be hands-on on a monthly basis.
Thank you. Yeah, I think that's really good feedback for new RDACs coming online. To turn it back over to Nevada for a second, I know that you all are still getting off the ground and you're still in the early phases, but have you found any success in engaging with your current state elected officials? I know that there is some state representation on your council itself.
So yes, we came online and started having meetings, and of course Nevada has every other year legislature, so we came online and had these discussions right in the heat of the moment, because our legislature only meets for 120 days every 2 years, so everything ends up being quite fast paced. So we decided from the main council to create a legislative subcommittee, and then within that legislative subcommittee we gave them authority from the main council to make decisions, review and surveil all of the upcoming BDRs. And then to the next one, we presented specific bills that we were looking at in terms of maybe perhaps what we would draft in terms of support. And then we worked very closely with our Attorney General to say, is this wording more in the advocacy of how it may impact rare disease? One of the biggest regrets, I guess, I have from our RDAC is if you are still in the formative phases from a legislative aspect, to avoid the biases of having to support or send letters on other senators or assembly people's behalf, is to give the RDAC a one legislative BDR access point so that they can present things on behalf of their own RDAC council, and they don't potentially have to go in an indirect way, because we also have duplicative efforts in our state with the Patient Protection Commission, and they have ability to present a certain number of BDRs per year. We don't have that authority legislatively. We have to either support them in their endeavors or speak with the legislators about how some of these decisions may impact the RDAC without lobbying in any way.
Yeah, that's helpful for folks who aren't familiar with Nevada's process. Can you speak to what a BDR is and what that looks like and why that matters to the council?
Yeah, so every bill that's submitted is in a bill draft request, and so it goes in from draft form to either the Senate or the Assembly. During that time, it is open for amendments. So if you read it and you think this might be a great opportunity, for example, we have a particular bill that is looking to make a registry for all types of different, it's like an all-payer claims database, and how that might impact rare disease. So you can support amendments that are inclusive with data that is directly reflective to rare disease and kind of track that through its progress. It definitely has to make it through the first house by a very, very swift deadline in Nevada, which that particular bill did make it. And then it goes into, of course, the finance division as to how might that bill impact the state at a financial level. A lot of bills end up dying in that committee just because fiscally we didn't know where we would be as a state. And unfortunately, way into the legislative session, we found out that our economic forum impact was not going to be as devastating as we thought it would be. But by then, many of these bills kind of lost momentum. So it's very important to be involved with them. And now that we're going into our interim session it's important now more than ever to be having conversations, inviting those legislators to our RDAC meetings so that they're familiar with us, so that at least when they are presenting these at the next submission of the BDR, they contact us and say, hey, I'm thinking about presenting this. How might it impact rare disease, and how might I formulate this language so it doesn't impact you guys negatively or you know, kind of go down a road that they just didn't anticipate.
Yeah, thank you. I think that's really helpful, especially that piece about, you know, inviting your legislators, you know, to come to meetings and building off of what Representative Albright, you know, was saying, you know, making sure that your legislators, you know who you are and know your purpose in your state is just really helpful. So thank you both for sharing that. This has been a really productive conversation, especially around the state engagement piece, but, you know, we're running close to time here. We're going to move into the Q&A section in just a minute, but before we go, can each of you share, you know, one tip that you would like new RDACs to know as they start, you know, getting off the ground in their state? Representative Albright, we can start with you.
Yeah, and thank you for the conversation, and that is the kind of the big question of the day. Yeah. Just know that it is an organic process that starts with legislation, and the more effort that you can put into the legislation up front in terms of definitively identifying what your scope and parameter is for the council, I think you save a lot of time on the backside, as we have sometimes sorting out the details in terms of how to go about the business of advocating for the rare disease community. And I can't say strongly enough just how important it is to have legislative action and involvement with this council to advocate with your legislators after the fact. Sadly, I think you lose time in the efficacy of moving forward. But if they're at the table as you craft that conversation, you have buy-in, you have an understanding, particularly as you know, you hear the stories. We also have a patient share their story at the beginning of every one of our meetings. It grounds you, and it reminds you of how important it is that the work that lay before you, and how impactful it is that the RDAC can be in the life of just even one patient.
Yes, thank you. Thank you. Dr. Burchell, we can turn it over to you. What's your one closing piece of wisdom?
It is to buddy up with another good RDAC that's already doing good work and steal all their ideas.
I like that. Don't reinvent the wheel. And Dr. Federizo, what's your one closing tip or piece of advice today?
I definitely second that. Find your network within NORD early. Find your regional NORD representative, because they will connect you to people that you didn't even know were out there who can support you. And then also make friends with your attorney general. Ours is exceptionally fabulous at email. So we just always want to make sure we're on the straight and narrow. And they have been fabulous in keeping us and saying, you know what, this is within your scope. You can do this, you can't do that, without us getting too far ahead. And then someone saying, no, wait up, you can't do that. So make friends with your attorney general and make friends with other RDACs too.
That's great. Thank you all so much. We have time for a couple questions. We're going to move over into the Q&A section. Representative Albright, we received a question about what resonates the most with legislators when you're speaking about your rare disease or your RDAC. What tips would you have, for an individual?
When you're meeting with a representative, you literally have about 3 minutes to make your case, whether that be in person, on phone, or in a Zoom call. And so be very quick. Don't bring a lot of paperwork. And don't smother us with data. It's important that you first state your case, state the problem, state a solution, and then bring a personal hook to the matter, whether that be a personal story about an individual that could be affected or was affected by this situation, and ask them point blank, will you help us? They are in the business of making black and white decisions for people. they have no trouble saying yes or no. If they say maybe, then ask when. But do not let them off the hook. They are in the business of, as I've said, working with three different groups of people: those in the dawn of life, those in the twilight of life, and as we are working with RDACs, those that are in somewhat the shadows of life, and they cannot be lost just because of inaction.
That's great. Thank you. I think that's going to be really helpful for all of the individuals that joined us on the call today. Dr. Federizo, how can an individual get involved who doesn't have a seat on the council? Are there ways that they can still become involved with your state's council?
Absolutely, and that's one of the beauties of public meetings, is that it's in full transparency. So every meeting that we schedule, whether that's the main council meeting or even the subcommittees, are publicly posted. I think when people think of publicly posted, they think easily accessible, not always two together. So sometimes you do have to dig a little bit, but that's one of the things we're trying to address with our website, is how to connect to those public postings through our website to the DHH website, which is not always as easy to get through.
That's great. Yeah, thank you for sharing that. And Dr. Burchell, we can go over to you now. What's one thing, in Tennessee, you spoke a lot today about how Tennessee is newer, but you certainly hit the ground running. What's one thing, though, that, surprised you while working on setting up the RDAC in your state?
We also looked into the University of Tennessee system. Our chair, Dr. Scott Strom, is a dean at the medical school there, and they have been sponsoring a lot of what we're doing, including the website and the tech that we needed to get that set up. And in retrospect, that was really a godsend, because it's helped smooth things quite a bit. And we didn't originally plan to do that. We're actually housed under TennCare, and so we thought we would be doing everything within the agency, but it's a lot harder and less nimble than it is to move through the university system. So I think if you can find especially a state university system, because then it's also still state funded to work within, that's a real boon.
That's great. Yeah, thanks for sharing that. I think we have time for one more question. And we received this questions a few times in the chat and in the pre-registration. RDACs have a lot on their plate. How does each of your states prioritize the work and the competing interests in your state? Representative Albright, can we start with you?
That's a tough question to answer, because it goes back to you just have so many different people with so many different and definable passions for really what they feel the objective of the RDAC is. You can't be everything to everyone. Mm-hmm. And I think that is part of each RDAC determining what is going to be their facility and their contribution to a larger kind of national RDAC network. And for ours, I think we've come to the realization that we have such a strong research capacity and an advocacy for the information that's coming into us, that I think that becomes our strength in terms of a warehouse of information that nationally people can plug into and then use that for their benefit, their betterment, and also as they meet with specialists, as they meet with other RDACs, and really just coalescing around this community nationally of centers that can provide information, care, but also support. Our survey brought up one of the most alarming situations is just the amount of support that was lacking in our care facility and our care environment for those suffering from rare diseases. And so that facility of providing information about support, whether it be mental, psychological, or just family support, I think is imperative and is a part of our RDAC.
Yeah, thank you. Nevada or Tennessee, any helpful advice for other new RDACs getting off the ground and ways to best prioritize your workload?
I think from our perspective, we have legislative objectives that the state put in for us to meet. Mm-hmm. And at first we look at them and there are more than 10, including the report wrap up that's required at the end of the year. And you look at them and you know that you're not going to meet that objective. But instead of saying, we don't meet that, that's an opportunity to say, the reason we can't meet this is because we don't have the funding, we don't have the infrastructure. So you still speak to those objectives, even if you can't achieve them. And then when you kind of get into that thought process, it's less of are we going to be able to meet what we're supposed to be as an RDAC? Yes, you're just moving everything forward. Now, are you there to solve them? No, that's going to take some time. But in the beginning, it's very overwhelming because to have 10 objectives, you're like, there's no way we can do this. So it's just kind of approaching each one individually.
Yeah, I think that's very helpful. And Dr. Burchell, let's close out with you. What's your how is Tennessee thinking about prioritizing their work, or have you found any helpful tips along the way in your journey that would help other states?
Well, I would say we haven't figured it out yet, but one of the helpful things we've done is to really have a cross section of the community on our RDAC. So we have patient representatives, we have scientists, we have MDs, we have representatives of nonprofit groups. We have all different sort of aspects of working with rare diseases and actually having rare diseases in the state. And so I think be really careful to make sure that you include people from the whole community when you form your RDAC. And in terms of our workload, we're still figuring it out. So hopefully the next time you ask me, I'll be able to tell you a great answer.
Well, thank you all so much. I think this was really helpful. I think that's all the time we have questions for today. But if you have additional questions, feel free to drop them in the chat and we can try and respond in real time today to answer them. A big thank you to our panelists for joining us and sharing their feedback and wisdom as they set up RDACs in their own states. And we hope that you found this discussion helpful. Thank you. To close us out today, I'd like to share a couple other opportunities and ways to get involved. First off, don't forget to download the toolkit we talked about today. It's a great resource for RDACs coming online. Second, stay tuned for some future meetings and webinar opportunities just like this one. This summer in particular, we'll be hosting workshops for current RDAC leaders that serve on their state's council. These meetings will be open just to RDAC leaders who are currently on their state council to gather together and learn from one another. We have a great set of workshops lined up. If you're interested in learning more about those, please contact us at RDAC@RareDiseases.org. In addition, stay tuned for our September stakeholders meeting. It will be open to all. We'll be discussing the successes and challenges of Project RDAC and what's on the horizon for RDACs in the coming years. Finally, don't forget to sign up to join NORD's Rare Action Network. It's a great way to get involved and stay up to date on meetings like this one, and also other state and federal legislative activities we have going on. As always, if you have any questions or want to get more involved in any of the states that we talked about today, please contact us at RDAC@RareDiseases.org. And finally, a big thanks to our Project RDAC supporters. Alexion, Biogen, Bluebird Bio, Boehringer Ingelheim, CSL Behring, Horizon, Genentech, Pfizer, Sarepta, Takeda, and Vertex. Without you, we wouldn't be able to do all of the activities with Project RDAC, and we very much appreciate your support. And finally, a big thank you to each of you for taking time out of your day to join us. We really appreciate you coming to learn more about RDACs and look forward to seeing you at a future opportunity. Take care and enjoy the rest of your afternoon.